So, ECG Pocket Brain, this is a book. I will share it with you later so you can read it through this one. It's possibly help you enough to build up the concept about ECG. What you need to see in the ECG is rate, rhythm, intervals, then axis if possible. So, we are going to check for the rate. Usually, there is not much you have to calculate from the boxes and everything. It's just too much if you want to like know everything about ECG, then you can remember the formulas, how much boxes or whatever it is. For your understanding, all you need to remember is it regular or is it irregular? The rhythm, basically. Okay. So divide the 300 by the number of the boxes in the R to R interval. So from one R to another R, how many boxes are there? That's what you have to divide by 300. It will give you an idea about rate. Simple. Then comes the rhythm. For me, I understand that with you, if you are able to calculate R to R boxes and the next R to R boxes, that will help you to figure out how much the rhythm is and is it regular or is it irregular by looking at that one. Then comes the interval, PR interval, QRS interval, and QT interval. So it should be PR interval should be more than 0.21. If QRS should be more than 0.10. So all you need to remember is how many boxes there should be between P to R interval, and then how many boxes should be between QRS intervals. Usually there is 1.5 box. For QT interval, how many boxes should be between QT interval and the normal one. Simple. You don't need to remember how much 0.201 and all that. If you can, that's a good thing. If you cannot, then it's also fine. Then we are talking about the key points. If the rhythm is sinus, the QRS is wide, then stop and figure out what's going on. It's either a bundle branch block going on. Then we are talking about axis, how we calculate the axis. We'll usually check for the lead one and AVF, how they should be. They're usually in the normal one. They are all positive. Both of them are positive. If lead one is negative, negative means the line that is below a normal one. So if we draw a line, the one that's below is basically negative. The one that's above is basically positive. So if the lead one is negative, then this is basically right axis deviation. And if the lead one is positive and the other one is negative, then this is basically left axis deviation. Simple as that. One straight lead one is compared with the AVF. Then the hypertrophy, how do you see the hypertrophy? All its thing is that the length will be very, very long. Okay. So how you're going to see the magic number of LVH are 35. So usually at the 12, and then true chambers is more likely if the strain are also present. So in the right one, like P pulmonal, in that one, the P waves are prominent and peaked. So if you can see, the more the length of, like length means the vertical that I'm talking about in like vertical form. The more it is high, the more hypertrophy is there. Simple, just to understand what it is. Now, if we are looking for the right one, in which lead you will see in basically second, third, and AVF, you see for the right one, and in the left one, usually we see in the 1, second, and the AVL. Okay, so for your understanding, all you need to remember is in which one we will see the leads. Okay, and then for hypertrophy, we see the vertical lens. Then consider the pulmonary disease. If there is an RAA, like means right pulmonal, and then right axis deviation, then along with that, this is basically the pulmonary disease. Usually they don't go into very much detail of this one. You just need to know the particular one. I will let you know which one are those ones. Then comes the infarct. In that one, we are going to check for the Q waves, R wave, ST segments, and T waves. Q waves is basically small and are present between where there is a previous MI present. And then R wave progression, the transition between V2 to V4. And then ST wave segments, more than amount of the ST segment deviation, focus on the shape, and then T waves. So I hope you have an idea about how PQRS or normal looks like. If you know normal, then you will be able to see which one is abnormal and which lead to see for which kind of disease. Simple. Then starting out the review of the basic, how we are going to start with the rate, rhythm, interval, axis, hypertrophy, and infarct. For me, if you are able to see the rate, if you are able to figure out if it's a regular rhythm, if it's an irregular rhythm, how much there is interval, like PR, how much boxes there should be. In QRS, there should be 1.5 box. Then in QT interval, there how much boxes there should be. If there is more than that boxes, just remember that 3 boxes or 2 boxes in that one, and from here to here this much boxes are there. If you remember the regular normal ones, you are good to find out that the interval is prolonged. And When you have seen so many normal ones, then you are able to figure out what's the difference between the irregular ones. Then the axis we already discussed, if one and AVF. Then hypertrophy, how we increase see the length. So that's more than enough. So in that one, the purpose of having a systematic approach is simple. If it provides us with the easy to remember mental checklist that prevents you from overlooking. Then we check for the accuracy, speed, and all of that. Then we are checking for the P waves, QRS with regular rhythm. If P waves related to QRS, if it's like, there is a gap between it. If PR interval is prolonged, that's what it is. Then the heart rate. Watch your P's and Q's and the three R's. Then in that cases, you have to see the P wave, the R wave, and there is three R's, like how much they are going on. How do you calculate the rate? Heart rate. I mean, if you can calculate all the boxes divided by 300, you are able to figure out what is the heart rate. That's very simple one, although there is other formulas too, and if you know those formulas, you can go with that one. But I find this very easy. So number of large boxes divided by 300, that will help you to figure out how much the heart rate it is. Then comes the two key list. So we are talking about large boxes, not the small boxes. So please see, like if there is two large boxes, then we have to divide the heart rate can be divided by the 300 by the number of large boxes. 300 divided by 2, so it's become 150. So 150 is the heart rate. That's how we calculate it. Then the two key list of the interpreting tachycardia is the first degrees checking for the like ST, VT, if the patient is stable or unstable. In that case, we are looking for that one. So how do you see the common causes of regular SVT are regular one, sinus tachycardia, atrial flutter, and PVST without any signs. In those cases, it's there. Sinus tachycardia is basically when the look at the rate. The rate is basically if it exceeds 160 per minute. So it means this is a tachycardia. And how do you calculate it? 300 divided by total number of big boxes. Big boxes is this one, like one big box and then the second big box. This one. Atrial fibrillation is ruling out if the rhythm is regular or irregular, mainly by checking that how many boxes are present between this long to another long one. So if this one has 1.5 box, then there should be 1.5 box in the next one. Then there should be 1.5 box in the next one. But in the atrial flutter, there is irregular going on. Sorry, atrial fibrillation, there is irregularity going on. Use of the Waggle maneuver, and then is the set 12 lead during the tachycardia. Then comes the if the QRS is wide, this makes the rhythm of WCT like a wide complex tachycardia. So there should be like a gap between them. So if the patient is hemodynamically stable or unstable, that's a different thing. Okay. Then ventricular tachycardia with the heart disease, and SVT with the pre-existing bundle branch block, and then SVT with the aberrant function. In that one, always assume that VT, treat the patient accordingly. So you have to see that assume that the patient is unstable, and then in that cases you have to go along with that one. So we are checking this one is the in and where do you check for the rhythm? Okay, one thing that I forgot to tell you, where are you going to check the rhythm? The lead 2 is the one that helps you to check the rhythm and also help you to give you an idea about the rate as well. So please, wherever you are checking for 4, 5, whatever the rhythm, but if you are checking for the lead 2, they have like the mainly for your understanding, if they give you an ECG and they give you usually in the ECG, the second lead is the one that is very elaborative. So rate, rhythm, this one helps from the lead 2. Okay, so if you are confused about anywhere else, go to lead 2 and check it from there if the rhythm is regular, if the rate is that one. Okay, then comes the acute interval. How much is the normal one? As you can see, then this one, how much is the P is basically you can remember how many boxes, the small boxes there should be. Almost around two small boxes is present between P wave, like that. The notch, there is only two small boxes, hardly two. I can say 1.5 boxes there. Okay, so then comes the QRS. So if you go into height of this one, there is only 1 or 1.5 box that is present there. Then we are going to check from Q to T. So you can see it's basically one big box and then another half of it is basically there. So usually if round about two boxes are there. Not all of them, but usually roundabout. I'm talking about roundabout. But more mainly it says 1.5 box should be present between Q to T interval. Then from R to R is basically 1, 2, 3, 4, 5, 6, 7. So almost 7 boxes are there in between R to R interval. So for your understanding, if you can memorize this one, this will help you to figure out if it's normal and abnormal or whatever it is. Okay, so you can see the long QT. If there, you remember, we were talking about how much the normal is basically 2 boxes, and if there's more than 2 boxes, it means the QT is long. Okay, so for my understanding, that's how I try to memorize that, the big boxes, how much are they present between them. If you can remember the small one, it's good. If you cannot, at least remember the big boxes. It will help you to figure out if there are more than two big boxes, if there are more than three big boxes, then what is the diagnosis. Is the QT prolonged? And then in contrast to the QT is obviously prolonged on the right one. So keep checking for the particularly speaking one that the QT intervals is normal, borderline, or whatever is going on. So where is the QT prolonged? In hypercalcemia. So you can see they have given you diagnosis of which condition the QT is interval is prolonged. Common causes of QT prolongation, the drugs, the CNS, sorry, the lights and then CNS. The drugs are which one? Quinidine, prokinamide. So we are talking about those ones. And then sotalol, amiodarone. TCS causes the QT prolongation, and then we're talking about the LTs. Lights, the hypokalemia cause PQT prolongation, and then hypercalcemia cause QT prolongation. The QT shortening causes by hypercalcemia, and QT prolongation caused by hypocalcemia. Okay, so CNS catastrophes like stroke and all of this also causes the QT prolongation. Now, common causes of the QT segment depression, which one are those ones? The ischemia, strain, digitalis, hypokalemia, hypomagnesemia, age-related, and any combination of the drug. The specific stage of the QT prolongation, so you have to see the basically the one we are talking about the strain. If you see the strain, that this is basically a little bit like a strain coming down. If ischemia, it's basically a dip that's present there. Then this normal one is basically where there is abnormal. There is no this inter T1, and then there is a big dip that is present. This one dig effect is there. So for your understanding, all you need to remember this ischemia. If they still give you a little bit of this one, a strain that you can remember, and then we know there is a T wave abnormal. The tall R wave in the lead V1, tall R wave is basically in the lead V1 is basically can give you an idea about the what's going on. So common causes of the tall R wave in the lead V1, what are those one? Wolff Parkinson White, right bundle branch block, right ventricular hypertrophy, position, posterior infarction, and then normal variants. So usually all you need to remember the main diagnosis is Wolff Parkinson White. In that one, there is basically QRS widening, short PR interval, delta waves is there, and then along with that, tall R wave in the lead one. Then the mirror effect is there. So as you can see, it's basically if the anterior ST elevation is basically in the setting of the acute inferior MI, reciprocal changes or concomitant anterior ischemia, posterior infarction could be there. So you will see that in lead one. So you need to remember which lead you will see for the anterior, which one is for a lateral, which one is for inferior. So 1, 2, and 3 in that one, we see the mirror effect. They are kind of similar going on how they are basically, that's basically an anterior one. Then if we are looking for the mirror effect in the opposite one, this is basically in the inferior lead. So don't go for into very detail of how the mirror test or whatever works for that. All you need to remember is there is ST elevation or there is ST depression, in which one it is that one. And in the lead one, what we will see for the like anterior lead, what are if there is anterior wall MI, which leads you have to see. That's about it. Don't go into very detail of mirror effect and all that. Then comes the bundle branch block, although it's very less likely that you will be able to make a diagnosis of left bundle branch block. But yeah, since we are doing it, let's go for that. So it's basically the QRS interval represents the changes, and then normally there is be complete in no more than 0.10. So I talk about one, there should be only one small box or maybe half of it. So QRS duration can be measured from any of the following 12 leads. So you can see mainly the lead 2 is the one that helps to figure out how much it is. If the QRS complex is wide, if the arrhythmia is supraventricular and QRS is wide, we suggest that you stop and your systemic approach and go for the patient stabilization. Now we are talking about the QRS widening. Stop, look at the 1, V1 and V6. In that case, is we are looking for what? We are looking for Wolf Parkinson White, or we are looking for any MI. Typical right bundle branch block, typical left bundle branch block, neither right or neither left one. So in that case, it's basically intermediate one. Then if the QRS is wide, now we are talking about QRS is wide. You all can, how do you remember that? If the QRS is wide, you can already think that there is some block going on. That's why it's taking a long period of time. So you can think of QRS is wide. This is basically a block going on. So this says there could be three possibilities. They are typical right one, they are typical left one, or they're either intermediate one, that intraventricular conduction delay. So three keys only. So the only three leads to determine the type of conduction block is basically lead 1, V1 and V6. We will check these ones. How do you check that this is right bundle branch block? There is QRS widening, that's we already know, or to at least 0.11 seconds. So there should be more than two boxes there. And then RSR interval in the lead 1. So in that cases, you can see that in the lead 1, this is how it is. And it's a little bit prolonged. So then there is V1 and V6 we see. And you can see a little bit of M here. Okay. So if you can see this M here, not a like W or M, whatever you can see from here. So in lead 1, if you can see that one, this is basically a right bundle branch block. And if the same W or M, whatever you can see in V6, this is basically left bundle branch block. Simple. That's how I try to remember. Right comes first, left comes late. So right in that one, we will see M in V1. If we see M in V6, it's basically left bundle branch block along with that QRS widening. I hope that makes sense to you. All you need to remember, like which points you are looking for. You don't have to go into very detail because this is how you actually work in the daily life too. So if you can pick up the few things, that will be more than enough for you. So you can see. Then we are talking about the memory aid that says R is basically they are talking about R, Q, R, S. So this how it is. So if you can remember this M1, that's more than enough. M is V1, and if this M is in V6, this is basically left bundle branch block. Then in the intermediate one, should be M in V1 and there should be M in V6 too. So we cannot tell it's either left one or it's a right one. So in that case, this is intraventricular. Hope that makes sense. This is a very straightforward thing. So you are going to check for M. If it's in V1, it's basically the right. If it's V6, it's the left. And if it's present in both, then it's intraventricular. Then we are talking about the typical secondary STT wave changes. So you can see the typical, and then we are talking about the typical left one. Then equivalents. Then we are talking about this one, hemi blocks. We did this one. Axis. So I hope you know the axis, how that works. So I told you you are going to check for lead 1 and ABF if they are positive, and normal should be positive. Okay. Then they are talking about QRST changes the basic lead groups. Inferior leads, this is one is basically 2, 3 AVF. In the lateral leads, we check for the lateral pericardial waves and which one V4, V6 and 1 and AVL. In the septal leads, which one is those one V1 and V2. Anterior leads is V2 and V4. So in that one, we are going to see they're talking about the QT interval T wave. So in this one, sphere leads may normally display moderate to severe Q waves, T wave inversion, particularly to a reverse Z, and may recall what leads there are. Then the chamber enlargement, left ventricular hypertrophy. It is kind of important because left ventricular hypertrophy is very common in the athletics and in the normal like people who are doing it. So in that one, simplified criteria is basically deepest S wave. So I told you the vertical length will be a little bit longer in the lead V1 and V2, and tallest R wave, and the patient should be more than 35 and left ventricular strain is there. Okay. So that will help you to figure out what's going on. I just wanted to focus more on the one that's more important. Then there is right ventricular hypertrophy. So you can see the opposite of those ones. So you can see the ST elevation. If this is how the conveyed one, convex one, there is a frowny, then there is smiley, and then there is J notch. So all you need to remember the ischemia and infarction one. So if there is an ischemia, the ST elevation is there and how they will look like. So you can see A, that is how it's gonna be like. the ST elevation. So usually the ST elevation where they are all started from here. So it started from here, then going to all of this level here. Then comes the pericarditis, which one that you are looking for, stage 1, stage 2, stage 3, and stage 4. That's what are you looking for. The everything is up in the stage 1. Then in the stage 2, this is stages are very, very important. Any stage can be given and can be asked. So in stage 2, there is a transition. So there is a little bit of this thing that moved to the next one, and then there is everything is down. In this one everything moved down, and then everything came back to normal. So this is stage 1, stage 2, stage 3, stage 4. So stage 2 can be given and stage 3 can be given along with the symptoms of pericarditis. Okay, then here is the pericarditis leads. Then the hyperkalemia. So we know that tall T waves could be present in hyperkalemia, like the Eiffel Tower. So that's how it is. Then hypokalemia, there is U wave. There is a dip in that one that's going down. So then this is the one. Okay, so that's all about it. I think they did not put the blocks here. We'll do the blocks from different where. Okay, so let's do a little bit of quick from pictures. So this is basically normal ECG. As you can see, I just leave it here for this one. So you can see from R to R, there is 1, 2, and 3, almost 3 boxes. 3 big boxes are present from R to R. In P, there is a one small box. In Q, there is one and not one, like one or maybe half box is present in QRS. And from the QRS to T, there is only one large box. So for your understanding, you can see how much is there. I mean, I have seen it so many times, so I could remember that this much is there. So for your understanding, you can remember the boxes. This will help you to figure out how much it is going on. Now, when we are talking about the atrial fibrillation, as you can see how the difference between the irregularly irregular. First of all, the P is not irregular. Okay. So the P wave, you can see there is no actual P wave, or there is P wave, but we are not able to figure out where is the P wave. And then the most important part is irregularly irregular. From R to R, the boxes are not similar. Someone has 2 boxes, some has 1 boxes, some has even half boxes. So if you can see, at least 3 of them should have different boxes. So this one is different, then there is a little bit more prolongation, there is a little bit more prolongation. So I calculated from here to here. So you can see this 2 or 3 is showing up the irregularly irregular rhythm. In this one, this is basically atrial fibrillation. I hope this makes sense. So this one is basically lead 2. We'll definitely checking the lead 2. I mean, if this whole thing is given, so you can see the lead 2 is the one that is actually elaborative here. So we are looking for lead 3, and then we are checking for how many boxes are present from R to R, and if you are able to figure out the P wave too. So some has P wave and there is some does not have P wave. So one thing is P wave, and then second is irregularly irregular rhythm. Then the absence of the P wave and irregular QRS interval. Then comes the pericarditis. There is PR elevation, ST depression, and ST elevation. So you can see there is ST elevation, so you don't mix it up with ST elevation. At the same time, there is ST depression. So you can think of, okay, why is there ST elevation and there is ST depression? At the same time, if you figure out there is PR elevation, then this is pericarditis. And usually you can find the PR depression as well. But the main thing that you will be able to figure out through some scenario that's given along with this ECG, that there is fever or something that can help you to figure out this is pericarditis. Then the diffuse ST elevation, you can see how big the ST elevation is going from here in the lead 4 and lead 5. So this is put here, how which one are you looking for, that one. So this one is lateral, this one is for inferior, this one is for septal, this is for anterior. So which leads we are talking about, where you have to see for the ST elevation. So anterior septal, so you can see there is the localization of how much and where you are going to see. Okay. So from your understanding, the lead 1 and lead AVL is for the lateral, and then A1, 3 and AVS is for the inferior. 1 and 2 is for the, sorry, 1 and 2 is for the anterior. And then if you can see the septal, second septal is also 1 and 2 and 3. And then 4, 5 and 6 is for the lateral leads. Then comes the hyperkalemia. So hyperkalemia is the tall T waves. That's what you have to see in that one. As you can see, they're so big. So don't mix up with this one with the hypertrophy. Hypertrophy, they will give you a scenario that, it's either maybe he's doing a prolonged exercise or whatever is going on. But usually there is a tall T waves or the tented T waves in the upside as well as the below side. So this one is basically short QT interval and peak T waves. That is one that give you this one. Then the sinus, six sinus rhythm. So there is no sinuses, sorry, there is no rhythm between the one between the other. So you can see there is a long, prolonged gap between that one. So this is basically six sinus rhythm. Then comes the pulmonary embolism. In the pulmonary embolism, you are going to check for the S waves in lead 1, Q wave in the lead 3, and inverted T waves in the lead 3. So it's very less likely they will give you a scenario where you are able to figure out what's pulmonary embolism. But just in case, if they have given you a patient is presented with you with shortness of breath and he's 35, he had gone through any surgery or something like that, and now we did his ECG and his ECG shows S wave in lead 1 or TQ wave in the lead 3. So what is your diagnosis? So if you are able to remember this one, this will help you to figure out this is pulmonary embolism. Okay. Then comes the heart blocks. That's what I was wanting to discuss. In the first degree heart block, this is regular. Only the prolongation of there is prolongation of the PR interval. So you will see there is like a little bit PR interval prolongation. So with the normal one, we saw that there is less than one block, and now in this one, there is a little bit wide as compared to the previous one. Now we are talking about that. So normal one is first degree AV block is basically normal. So we don't have to do anything with this one. Usually what they do like to ask is the second degree Mobitz type 1 and second degree Mobitz type 2. So that makes a lot of confusion. How do you check for the type 1 for the Mobitz one? There is an increased prolongation and there is a dip. So there is an irregular. Although P wave is regular, so you will be able to find PR, P wave. From one P wave to other P wave, the boxes will be regular. Okay. But you will find in after 3 or after 4 PQRS interval, there is one no QRS. So there is one loss of QRS. So as you can see, there is one here, there's one here, there's one here, but there is one that's lost. That's why it's irregular, because we are checking from Q to Q, sorry, R to R. So if you can see from here R to here R, it's regular. From this R to this R is regular. From this R to next R, there is no R here. So that's why their boxes become prolonged. So that's why it becomes irregular. But it's not irregularly irregular, because that is going on for long. Like you will see all the boxes have the irregular one. Here, the other ones are regular, which one are there, but there is one dip or there is a one missing one. That's why they become irregular. I hope that makes sense. Then there is an increased prolongation of the rhythm. So you can see after P, there is a little bit prolongation. That's significantly very important. Okay. So between P to QRS, there's a little bit prolongation. That's what we are talking about. Then comes in this one, it's basically irregular. In this one, what happened is there is normal P wave is normal, but the QRS, after QRS there is a very prolonged gap, and then there is another one. So if you can see in the Mobitz type 1 and Mobitz type 2, the difference is here the gap will be coming after 3 to 4 to 5 of the QRS, normal QRS, but here after every 2 or 3 there is a big gap. So you will be able to figure out, because they will give you a very long or not a little bit, at least you will be able to tell that after 2 or 3 there is a gap or no gap. If there is a after 2 or 3 there is a more gaps that you figure out, then this is a second type 2, and if there is less gap, then this is basically type 1. Okay. Then in third, nothing is figured out. You cannot tell, like either there is P, there is R, or whatever it is going on. So you will see a lot of dips, like there is a missing QRS. Okay. So that's how you figure out what's the difference between the degree of the blocks is very, 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 very important. Please, if you are not able to do any ECG, at least do the degree of blocks, the atrial fibrillation, and what else? Yeah, hyperkalemia and MI. Okay. So these are 4 5 that you have to do, a lot of them. If you are not able to do like other ECGs, if you are doing able to do the other one, then it's good. If not, at least do blocks, MI, hyperkalemia, like electrolytes, hypocalcemia as well, hyperkalemia, hypercalcemia, and then the atrial fibrillation. Okay. Sorry, ventricular tachycardia as well. Yeah. So we are talking about this one here, bundle branch block. So we did discuss a little bit of bundle branch block. You can see the M, if it's in the V1, then it's basically right one. If it's in the V6, then it's basically the left one. Then we are talking about the supraventricular tachycardia. So in this one, it's from supraventricular tachycardia, you can remember it's super narrow. Okay. So you will see, even the picture looks like horrible, like it's so narrow. So you can tell that this is basically supraventricular tachycardia. So a scenario can be given a young girl with multiple brief episodes of palpitation, dizziness, and lightheadedness, and ECG is attached. So you can see there is so much tachycardia going on. Everything is regular. There is P wave, there is QRS, everything is regular. But you know what is everything is going on so fast. So you can see this is supraventricular tachycardia. Then comes the ventricular tachycardia. Now everything becomes so wide. So you can see this is basically ventricular tachycardia. Although you will be able to figure out there is P wave, there is RQRS, everything, but there is wide. So this is ventricular tachycardia. We will decide if the patient is stable or unstable. On the basis of that, we will go for the cardioversion or not. Then you can see the Wolf Parkinson white. So in this one, all you need to see is the short PR interval that is basically there. So you can see. So I do put important ones here so you can see from here. So this much is the ECG. I hope you don't have any question. If you don't have any question, then we can proceed forward. If you still have any question, please do let me know so we can do a little bit more about
Can we
ECG.
get these two documents?
Sorry?
The two ECGs, the two ECG documents you showed, the first one and this one. Can we get?
Yeah. I'll send it. I'll send it.
Yeah, thank you.
Please go
Thank you
ahead.
very much.
Yeah, no worries. So do go through this one and then try to figure out what is there in the differential diagnosis of QT prolongation. What is the difference between what are the differential diagnosis of QT prolongation? What are the differences of the PR prolongation? That also helps you to, make the diagnosis when you are doing that. And if you have too much time, then do it. If you don't have too much time, then just do what I told you. Don't, mix up your concepts. Let's continue with this one. This is just a little bit of organisms, malaria, lymphoma, leukemia, inclusion bodies, toxoplasmosis. Then the blood films look like this, schistosomiasis, the non-squamous cell carcinoma. Okay. So we are talking about the hypertensive retinopathy. That's how they look like. This is how the hypertensive retinopathy, there is like blood vessels that is here. So you can see this is a wet form and this is dry form. For the macular degeneration, if you could able to do difference from the scenario, it's more than enough. Usually for the hypertensive retinopathy and this one, it's seen by a ophthalmologist, but you never know if a scenario can come and ask you to make the diagnosis. The glaucoma is important. Okay. So you can see there is a halo along with this one. So that can help you that one. Okay. So now this one is important. The trichiasis, misdirection of the lashes that is going inside and poking in the eyes. Then the symplebron, basically fibrosis between the lid and the globe. Then the ectropion. So there is basically eversion of the eyelid and the eyelashes. So there's like, it's mainly in the hypothyroidism. Then the ankyloblepharon, so this is basically attached the eyelids. Then the tropion, so inward rolling of the eyelids. Then the blepharophthalmitis, this is basically it's a small palpable aperture that's basically swollen. So we are talking about the unilateral redness and watery discharge of the follicles, viral conjunctivitis, if bilateral itchy, uh, allergy or papilla, and then this is basically conjunctivitis, white rim. As you can see, there is white rim right next to conjunctiva here. Okay. I just put it here because for the pictures wise, according to like eyes, they can put you, and ask you. Then this is a uveitis. Then this is orbital cellulitis. Orbital cellulitis and periorbital cellulitis, they both are important because they can present in the scenario. So this is basically lesion, painless granulomatous of inflammation, glands and the obstruction. And then this is also sty, corneal abrasion stained with the fluorescent. So they put it this one. Then the treatment is antibiotics. So you can see there's double row of the eyelids that can keep poking the eye too. This is diastasis. This is trichiasis, inward eyelashes. And then again the clasion. How does they look like? The sty is like this. External hordeum is stia, and then internal hordeolum is basically sty, and then this is clasion. So hordeolum and sorry, sty and then clasion, what's the difference between them? Most likely found at or near at the eyelashes. Most commonly found, so clasion is most commonly found around the eyelashes of the upper lid. So that's present over there. And this is present during near the eyelash follicles. So the mainly that for sty, there is a bacterial infection. For clasion, there is a blocked oil duct. In this one, there is tenderness and swelling. In this one, this is a painful lump. And for the sty, you do have to do the spontaneous puncture or warm compressor. In the clasion, we do the warm compression and give the antibiotics. Although for sty, we also give the antibiotics. Okay, so you can see this is at the edge and this is away from the edge. Okay, that's the main difference. Okay, then they put the third nerve palsy, the fourth nerve, and then fifth nerve. So I keep on saying the lichen planus and lichen sclerosis. How does they look like the other picture? Then we are talking about the Opgine variable deceleration, how they do look like. So you can see this is not even the equal. That's why this is variable deceleration. It could be the cord compression. Then comes the early deceleration, which is normal. It could be head compression. Then comes the late deceleration, which could be the placental insufficiency. Then the X-rays, this is leg cuff part. This is, you can see that these destroyed fragmented femoral head. This is skiffy, medial slip of the epiphyse is disrupted. And there is cleanse line that is broken. And then you can see this is the DDH. Because of that one, the line is broken. And vestibular angle is 30, ossification center outside the inner lower quadrant. Now comes the dermatology. So this is alopecia areata because the head is shiny and then the thing is comes in like a circular one. So it could be confused with the trichotillomania or it could be confused with the tinea. So this is basically alopecia areata because it has like a shiny one. It does not show any kind of redness or any kind of inflammation, or it does not show any broken hairs. Okay. Then comes the seborrheic dermatitis. As you can see, there is like a dryness and then yellow patches. So don't, or there is mainly the dryness, dry patches here. That's why it's a seborrheic dermatitis. So don't mix it up with the impetigo or anything else. Then comes the rosacea. So it's mainly on the cheeks, the nose, or the forehead. That could be there. So mainly this is the presentation and it could present only on the cheeks, either only on the nose or either only on the forehead. So for that one, you have to keep it in your head. It could be presented with any autoimmune disease and it could be triggered with any uh, sorry, cold weather or any stress, anything like that. So I just recently saw a patient, she was mainly get triggered with this condition only in cold weather. So you have to see this one and you have to keep it in your head. It could, which diseases that are linked with this one. So the question is not only limited to asking you to make the diagnosis, they can ask you a picture and ask them which diagnosis or which disease could be linked with the with this condition.